Have you ever felt a fiery, burning sensation rising from your stomach up into your chest? Maybe right after a heavy meal or the moment you lie down? That is heartburn. And if it happens regularly, it might be more than just a passing annoyance. It could be gastroesophageal reflux disease, commonly known as GERD. Welcome back to Dr. Zaki, Gut and Liver Health. I am Dr. Zaki, a gastroenterology specialist. Today we are taking a deep dive into GERD. It affects up to 1/3 of the adult population in the U.S., but it is deeply misunderstood. Today we will explore exactly what is mechanically going wrong inside your body, the alarm symptoms you can never ignore, and the science-backed lifestyle changes and medical treatments that can actually help you fix it. Let's get started. To understand GERD, we have to look at the mechanics of your digestive tract. At the bottom of your esophagus, there is a muscular valve called the lower esophageal sphincter, or LES. In a healthy gut, this valve opens to let food in and closes tightly to keep stomach acid and digestive juices where they belong. But in GERD, this barrier fails. Acid, pepsin, and sometimes bile easily flow backward into the esophagus, causing prolonged, damaging contact with your delicate esophageal lining. The most common symptoms you will feel are heartburn, that substernal burning sensation, and regurgitation, which is the effortless return of sour or bitter gastric contents into your mouth. Now, some people blame their chronic cough, asthma, or a hoarse voice on GERD. However, clinical guidelines tell us that these extraesophageal symptoms actually have a much lower likelihood of being directly caused by acid reflux compared to classic heartburn. If you have isolated throat clearing or a cough without any heartburn, the cause is often something else entirely. So how do we diagnose GERD? For most patients with classic symptoms of heartburn and regurgitation, we start with an 8-week trial of medications called proton pump inhibitors, or PPIs, taken once daily before a meal. If your symptoms completely disappear, it strongly points to a diagnosis of GERD. However, there are specific alarm symptoms that mean we skip the medication trial and go straight to an upper endoscopy. These red flags include trouble swallowing, pain with swallowing, unexplained weight loss, persistent vomiting, signs of gastrointestinal bleeding, or unexplained iron deficiency anemia. During an endoscopy, we look for objective evidence of acid damage. We might see erosive esophagitis, which we grade from A to D. Grades B, C, and D are conclusive proof of GERD. We also look for complications like peptic strictures, which are narrowings of the esophagus, or Barrett's esophagus, a precancerous change in the esophageal lining. If your endoscopy is totally normal, but you still have severe symptoms, we use specialized reflux monitoring, like a wireless pH capsule, to measure the exact amount of acid entering your esophagus over several days. Now, let's talk about how to fix it, starting with lifestyle and diet. The clinical evidence strongly supports a few key changes. First, if you are overweight, weight loss is highly recommended, as excess weight increases intra-abdominal pressure and physically drives reflux. Second, elevate the head of your bed. This simple gravity-assisted trick reduces nighttime acid exposure. Third, avoid eating meals within 2 to 3 hours of going to sleep. Lying down flat with a full stomach is a perfect recipe for nocturnal reflux. Finally, consider avoiding trigger foods. Things like coffee, chocolate, citrus fruits, spicy meals, and high-fat foods can relax the lower esophageal sphincter or directly irritate the esophageal lining. Also, if you smoke, quit immediately. Smoking cessation has been shown to significantly improve GERD symptoms. When lifestyle changes aren't enough, we turn to medical therapy. Proton pump inhibitors, or PPIs, are the most effective medications for healing erosive esophagitis and controlling symptoms. For maximum effect, they must be taken 30 to 60 minutes before a meal, usually breakfast. Some patients worry about the long-term safety of PPIs due to alarming news headlines. However, high-quality prospective studies show that while there is a modestly increased risk of enteric infections, the other heavily publicized risks, like dementia or heart attacks, lack strong cause and effect evidence. For patients with severe erosive esophagitis, long-term PPI therapy is absolutely recommended because the damage will almost certainly return if the medication is stopped. But what if medications fail, or you don't want to take pills forever? For patients with objective evidence of GERD, anti-reflux surgery by an experienced surgeon is a great long-term option. The traditional surgery is a fundoplication, where the top of the stomach is wrapped around the lower esophagus to recreate the valve. Interestingly, European guidelines now suggest that a partial posterior wrap is preferred over a total 360-degree wrap, as it provides similar reflux control but significantly lowers the risk of postoperative swallowing difficulties. Another surgical option is magnetic sphincter augmentation, or MSA, where a small flexible ring of magnetic titanium beads is placed around the esophagus to prevent acid from backing up. This is highly effective, especially for patients whose main problem is persistent regurgitation. GERD is incredibly common, but you do not have to live with the burn. By understanding your triggers, getting the right diagnostic tests, and working with your doctor on a tailored treatment plan, whether that is lifestyle optimization, medication, or surgery, you can take back control of your gut health. If you found this medical breakdown helpful, please hit the like button and subscribe to Dr. Zaki Gut and Liver Health for more evidence-based videos. Let me know in the comments below what gut topic you want me to cover next. Until next time, take care of your gut